Good morning, good afternoon, good evening, and good night, friends and colleagues from across the world. Thank you for joining us today on our special edition Podinar with a very special guest, Dr. Timothy Ricks, DMD, MPH, FICD. Dr. Ricks, thank you for joining us today.
Thank you, Dr. Shah, for having me.
It's quite an honor of my career to host you today for this Podinar pertaining to the upcoming Surgeon General reports on oral health. But first, before we get into that, Dr. Ricks, I'd like to familiarize the audience with our Assistant Surgeon General of the United States, Dr. Timothy Ricks. Again, DMD, MPH, FICD currently serves as the 19th Chief Dental Officer of the U.S. Public Health Services, as well as Assistant Surgeon General. He serves as a Surgeon General spokesperson on oral health and interacts with Chief Dental Officers from other countries, with military Chief Dental Officers, with leaders in organized dentistry, with state and oral health programs, and much more. He's currently overseeing the development of the second ever Surgeon General's report on oral health. Rear Admiral Ricks has served in the U.S. Public Health Service for over 21 years. Prior to this service, he was an associate dentist, independent contractor, and sole proprietor, and he has also served as a military police officer in the Army National Guard. He served as a delegate in the ADA House of Delegates and frequently interacts with ADA leadership, the Council on Government Affairs, and the Council on Advocacy for Access and Prevention. Wow, Dr. Ricks, what a career you have had. Thank you for your service to our country and to our profession.
Thank you, Dr. Shah.
So expanding to almost 3 decades, tell us a little bit about where you went to dental school and how you got here.
Okay. Well, so I grew up in Mississippi, a small town in Mississippi, and I went to my undergraduate training in the Mississippi Delta State University. And when I finished there, I was accepted into the University of Mississippi Medical Center School of Dentistry, which is in Jackson, Mississippi. I graduated. I was very fortunate to have an excellent faculty that taught me things that I'm not sure other dental schools taught at the time. I mean, there was a real heavy emphasis on dental public health and things like that. And I remember we set aside time each year to do community-based projects that we would develop. So that kind of was the spark that led me into thinking about public health early on. And I remember my last year in dental school hearing a recruiter from the Indian Health Service speak to my school. And they passed out literature and things. And I remember just packing it away because there were a lot of recruiters that come to schools, military, different agencies and so forth. So I packed it away, forgot about it. And like most people, when I graduated from dental school, I went into private practice. I first began as an associate dentist at a practice in the Mississippi Delta. And when I was, I treated a very underserved and vulnerable population there. And I really enjoyed not just the clinical aspects of dentistry, but I really enjoyed going to the schools, going to the Head Starts, doing things out in the community that were oral health focused. And then following that, I was an independent contractor at a practice that I later bought and became a sole proprietor. And it was sort of the same story. That was in central Mississippi. And I really enjoyed treating especially Head Start and Medicaid patients and those that really had problems accessing care. But I had this inner calling throughout my time in private practice. And I remembered the Indian Health Service. So I dug through all my old notes and found that one brochure on the Indian Health Service, and I gave them a call in 1998, and I was called to active duty. We're one of 7 uniformed services, the U.S. Public Health Service is. And, I'll talk about this a little bit later, but the Indian Health Service is one of the agencies where Public Health Service dental officers serve. So anyway, in January of 1999, I began my career with the Indian Health Service and moved from Mississippi all the way to Reno, Nevada. And that's a bit of a culture shock, moving from the deep south to the west coast. But I stayed there do you want me to keep going, Dr. Shah, and tell
No,
me?
I'm very fascinated. I used to practice in Southern Illinois, and I'm on the same wavelength as you, because access is very hard for people that are in smaller communities where you have 50, 60 miles before you can get to a surgeon or a specialist or something of that sort. It gets a little tricky. So very honorable what you were doing there. So please, no, continue.
Well, so I joined the Indian Health Service, and the Indian Health Service, like I said, is an agency within the Department of Health and Human Services. It serves 2.3 million American Indians and Alaska Natives, a historically underserved population with a lot of a disease, including dental disease. And so I served at the Pyramid Lake Paiute Tribal Health Clinic in a town north of Reno, Nevada. And if you ever get the chance, there's a beautiful lake called Pyramid Lake. It feeds into Lake Tahoe. I think everybody's familiar with Lake Tahoe, but Pyramid Lake is wonderful. And what I really enjoyed about those early years was moving from private practice into public health. In private practice, you had to sell treatment plans. You had to, patients made decisions. A lot of it was based on cost. And with the Indian Health Service, all the care that's provided is free. There's no payment. So you could, I had the opportunity to do what was 100% the best treatment every single time. And I didn't have to worry about their ability to pay. And while I was out at Pyramid Lake, I'll say in those early years, what I really enjoyed was going fishing at Pyramid Lake and catching these huge, and the screen's not big enough to show you how big these trout were, but they're Lahontan cutthroat trout. So if you're a fisherman, that is the place to go. But anyway, back to the dentistry. I really enjoyed the dentistry that I was able to provide. I fluoridated the entire reservation. Got the back to the dentistry water system operator. Really enjoyed the dentistry that I was able to provide. I fluoridated the entire. There's a little bit of delay in the microphone.
Right, no, you're good. You're good now.
But anyway, after Pyramid Lake, while I was there, I became a medical director in addition to a clinic director. So I ended up overseeing 7 different programs in Nevada, spread from the Oregon border all the way down to central Nevada, and became the medical director as well. And then in 2006, I accepted a job as the area or regional dental officer for the Nashville Area Indian Health Service. So the Indian Health Service is divided into regions or areas, 12 of them, and one of them was based in Nashville, Tennessee. And in that capacity, I oversaw 27 different programs from Maine to South Florida to East Texas. So there, just by me describing it, you can tell that I traveled quite a bit to go out to support all of these different clinics. And it was an adventure, standardizing policies and procedures across all of these programs and helping with the hiring of high quality dental staff and things like that. and also served while I was in that position as the director of the Office of Public Health. So I oversaw the medical program, the behavioral health program, pharmacy program, nursing program, and various other health programs in that region that with 27 different ambulatory, our hospital, I think we had 2 hospital programs and the rest were ambulatory. And then in 2006, that was 2006. In 2012, I became a regional or area dental officer for the Albuquerque area in addition to the Nashville area. So the Albuquerque area is based in Albuquerque, New Mexico, and I oversaw 21 additional programs in Colorado, West Texas, and New Mexico. And again, a lot of travel getting out to all those programs. And so I held the dual positions until 2016. And in 2016, July of 2016, I was hired as deputy director in the Indian Health Service Division of Oral Health. That's our headquarters in Rockville, Maryland. So I actually, today, I'm talking to you from Nashville, Tennessee, where I continue to live, but I have an office in Rockville, Maryland as well. So dual offices. And then my Indian Health Service job, I actually have several. I'm the continuing education director for our IHS continuing education program. We have about 300 continuing education courses that we hold each year, in person, online, and so forth. And then we also serve as the National Prevention Coordinator, or we call it Oral Health Promotion Disease Prevention. And so I've been able to create some initiatives such as an early childhood caries initiative that led to the first ever decrease in early childhood caries in American Indians and Alaska Natives, and some other projects. And this year we're working on an elder care oral health initiative. And I say this year, this fiscal year, so really 2021. So that's one of my jobs. And then in September of 2018, I was appointed by the U.S. Surgeon General, Vice Admiral Jerome Adams, to serve as the Chief Dental Officer. And so I hold this job that's in addition to the Indian Health Service jobs. Wow. So but it's been an adventure and I enjoy every minute of it.
Yes, you have dedicated your life pretty much to dentistry and healthcare. It's very admirable. Dr. Ricks, you also became a rear admiral somewhere along the line. Can you tell us a little bit more about that? It's a very high rank in the Navy.
It is. And so the Public Health Service is one of 7 uniformed services: Army, Air Force, Navy, Marines, Coast Guard, NOAA, the Space Force, and the Public Health Service. Public Health Service was formed in 1798. And for the most part, we wear Navy uniforms and use the Navy rank structure. So I began as, for those familiar with the military structure, an 03, and then I slowly worked my way up to 06, which is captain. And then when I was appointed as the Assistant Surgeon General in 2018, with it came the rank of Rear Admiral. So that is how I got there.
Wow, this is, you know, I thought I've done a lot, and I've seen a lot of colleagues come to this show that have done a lot in their careers, but you, my God. All right. Well, we're glad to have people like yourself, professionals and colleagues in charge of these divisions. And you do something else also, which is of interest: expanded functional dental assistant program. You know, we're always interested in improving the skills and knowledge of dental assistants and people that work with us chairside and within the practice. What does that entail?
So, Dr. Shah, so the Indian Health Service actually was the pioneer in expanded function dental assistance. So back in 1961, the Indian Health Service first started training dental assistants to do restorations after a dentist would prep the tooth. And then, of course, would be under the general supervision of the dentist. So the dentist would hop to the next chair, and so it increased productivity and efficiency by having a dental assistant do the amalgam, or, now a lot of composites or glass ionomers as well. So our program in the Indian Health Service, we hold about 20 restorative expanded function courses each year, training anywhere from 8 to 12 dental assistants at a time. And they have a pre-course set of modules they complete, and then they go through week-long training with quality checks along the way, clinical test, and then they're sent back to their clinic, wherever it is across the country, and then they have to do so many restorations under the direct supervision of the supervising dentist, and then they're certified. And we train them to do. There's 3 different levels. We have a basic expanded function dental assistant that can do mostly amalgams, some small composites, and then an advanced who they can do class 4s, for example, class 3s. And then now we have just started this last year, we have a composite only expanded function dental assistant. So they learn all composite. So those are the 3 different levels of the restorative, but we also have a periodontal expanded function dental assistant. So one of the things, we are in short supply in the Indian Health Service of not just dentists, but also dental hygienists. And so the dental hygienists that we have, we want to really have them focus on the severe disease. And so we train dental assistants to do routine prophies and use ultrasonics, piezons, cavitrons, and so forth. And it follows the same kind of curriculum, a pre-course set of modules, a week-long training, and then post-course direct supervision by a dentist or hygienist, and then they're certified. So we really ramped up this program in 2016, and at this point, out of our 2,000 plus dental assistants in our system, about 2/3 of them are expanded function.
Wow. This is a really interesting topic. I don't know if you guys have also considered expanding this into oral surgery and other verticals, because as you've said, we have certain shortages. For instance, over 120 million Americans are wrestling with edentulosum, have at least one missing tooth and above. We don't have enough GPs performing this procedure, and we don't have enough oral surgeons to render this type of care, or periodontists. So we have to work in a multidisciplinary approach and work with each other to solve this massive problem. And you guys are doing a great thing. You guys do any kind of emergency training with these assistants as well?
I mean, yeah, I think, are you talking like oral surgery or like medical emergencies?
Medical emergencies, things like that.
Oh, yeah. Yeah, we have several courses on medical emergencies in the dental office. And I will say, since you mentioned oral surgery, we do have oral surgeons. Most of them are based in our hospitals. We have 46 hospitals in our system. And so we do have some oral surgeons, and they do train their dental assistants to do some advanced things. Orthodontics, the same way. We have a couple orthodontic programs, and they have some expanded function dental assistants as well.
Excellent. So it's now the public dentistry, public health system. It's now recognized as a specialty. At the beginning, you said something very important that our younger colleagues might be very interested in. When we went into dental school at a medical profession, we wanted to care for people. we wanted to have the ability to do so. And you said that when you started doing that, and you didn't have the challenges of the whole financial aspect and having to require payment from the patient, changed your way of practicing dentistry and providing the best kind of healthcare you could to your patients. What would you say to a younger dentist that wants to explore public services in regards to that?
Well, I mean, I think the way dental schools, the curriculum's set up, it teaches us to, or sort of leads us into private practice. And there's no, I mean, private practitioners have a important role in improving the oral health. If you have a desire to treat those who are less advantaged, those that are more vulnerable to disease, more vulnerable to not having access to oral health care, then public health may be the place for you. So what you could do is, if you're a student, there are externship programs in public health. So that's an opportunity. If you're a new dentist, you know, maybe you could visit a community health center, perhaps volunteer. There are multiple community health centers that take volunteer dentists, and volunteer for a few hours or a half day and see how that works for you. And, you know, if it's desirable, then maybe consider a career in public health. The transition is much easier than you think. So I did it, and anyone can do it.
Yes, and look at what you have achieved. Countless programs, service to the country, and it's ongoing and it's continuously growing. We're very appreciative of that. Well, Dr. Ricks, I really thank you for the quick introduction. Today you will be talking to us about the second ever report that's coming out. I'll wait for the entire for the presentation. So with that basically said, you have the floor. Please go ahead and let's begin this discussion. I'm going to disappear.
All right, that sounds good. Okay, so thank you again, Dr. Shah. And can you see my slides okay? I think you're muted.
Yes, we can see your slide.
Okay, wonderful. So what I'm going to do is I'm going to give you an overview of some of the issues that have led to this second ever Surgeon General's report on oral health. And while I'm at it, talk about our Surgeon General and some of his priorities. So with every presentation, I always start with learning objectives, and I'll just let you read this to yourself for a second. Okay, so let me introduce you. If you don't know him, our current Surgeon General is Vice Admiral, which is a 3-star admiral, Vice Admiral Jerome Adams, MD, MPH. He is the 20th Surgeon General of the United States. And as the nation's doctor, his mission is to advance the health of the American people. And his mantra is that together we can achieve better health through better partnerships. To learn more about Dr. Adams, you can visit the website that I've listed there. Admiral Adams, like previous Surgeons General, has set priorities to help advance the nation's health. So we'll spend some time discussing each of these 6 priorities and what they mean to improving the health of our nation. These priorities include opioids and addiction, tobacco, community health and economic prosperity, health and national security, emerging public health threats, and most important to us, oral health. He is the second Surgeon General to describe or list oral health as one of his top priorities. So let me begin by starting with oral health. So Dr. Shah mentioned the second ever report on oral health, and I'll talk about that in a minute. But the first report on oral health was commissioned by then U.S. Surgeon General Vice Admiral David Satcher back in 2000. It was entitled Oral Health in America, and it had as its major message that oral health means much more than just healthy teeth, and that it's integral to the overall health and well-being of all Americans. Now, there had been plenty of research that showed the links between oral disease and systemic disease, especially within regard to periodontitis, but really, and that had been going for 50, 60 years before this report. But this report really is often credited as taking that conversation to the next level and really getting our medical colleagues on board with understanding the relationship between oral disease and systemic disease. As a follow-up to that report in 2000, there was a 2003 call to action that listed some specific actions that the country could take, policymakers, medical professionals, oral health professionals. And some of those goals in that call to action were to promote oral health to improve quality of life, and most importantly, to eliminate oral health disparities. And I'll come back to that third point in a minute because I think it's really important. But before I go into that point, I want to give you just some key global oral health facts, and this is from the International Dental Federation. Dental disease, we know, continues to plague our country and the world. 44% of the world's population has untreated dental caries. And in fact, the Lancet, which is a British publication, in their ranking of the top 30 disease conditions, they rank 328 of them every few years. And out of the top 30, dental conditions constitute 4 out of the top 30, with untreated dental caries and permanent teeth being the top disease burden globally. So the 60 to 90% of school children have caries experience. And again, caries experience means just what it says, any history of dental caries. So whether it's been filled, extracted, or is active caries, that is caries experience. 15 to 20% of adults 35 to 44 have severe periodontitis or periodontal disease, and that's characterized by a community periodontal index or periodontal screening and recording score of 4, or which means 5.5 millimeters or more. 30% of older adults aged 65 to 74 have no natural teeth. And this, of course, we know disproportionately affects older adults in poverty. We also know that oral conditions are the 4th most expensive to treat. And then interestingly, over the past 5 decades, what we've seen is that worldwide sugar consumption has more than tripled. And we know the relationship between that and dental caries. But I want to go back to that point about one of the goals being to eliminate oral health disparities. And we don't like to just say oral health disparities. We like to call it now oral health inequities, because there is an element of social injustice with relation to access to care and so forth. And I'll talk about that in a minute. But if you look at the 3rd through 5th rows on this table, where it starts with white non-Hispanic Americans, and if you look at the different categories, caries in 2 to 5, 6 to 11-year-olds, 12 to 19, untreated decay in 65 and over, and total tooth loss, what you can see is that in relation to all these different variables, Black non-Hispanic Americans and Mexican Americans suffer disproportionately from dental disease, as much as 2.5 times that of white non-Hispanic Americans. Similarly, if you look at those bottom 2 rows and you look at those that are at or below 200% of the federal poverty level, which is currently around $25,000 for a family of 4, what you'll see is that they suffer disproportionately from dental disease compared to those that are at or above 200% of the FPL. So these are recent data and show that we still have not achieved that goal, or we've not even come close to achieving the goal that was set forth in 2000 to eliminate oral health disparities. One of the things, though, when we talk about oral health disparities, there are a lot of influences on oral health delivery of care. So the cornerstone of delivering quality oral health care is access to care. And this is driven by demand for services, the available workforce to provide those services, and economic conditions that affect demand and the workforce, which with COVID-19, for example, we've seen a huge impact on the economic conditions as it relates to dentistry. But there are other factors as well, as we know, such as social determinants of health and oral health literacy that also play into this equation. One of the primary drivers in access to care is the economic influences, as I mentioned. According to data from the American Dental Association Health Policy Institute, total dental expenditures have more than doubled over the past 25 years, from roughly $60 billion in 1990 to $120 billion in 2016, and that's adjusted for inflation. If we look at it as per capita dental spending, which is also adjusted for inflation and is shown on this line graph, we see that per capita spending has increased from $232 in 1990 to $413 in 2018. We also see that because of these increased costs, dental care consistently ranks at the top in terms of people foregoing care, with almost twice as many Americans foregoing dental care due to cost as those who don't get their prescription drugs, medical care, or optical care because of cost. So for many Americans, dental care is still considered a luxury. Another driver of access to care is the availability of dental care in large portions of our country. The Health Resources and Services Administration, or HRSA, designates health professional shortage areas in primary care, mental health, and oral health. If you look at this map, what you can see, these gray shaded areas are designated dental health professional shortage areas, or HPSAS. And for those interested, Nebraska uses a different methodology, but most of Nebraska should be shaded gray as well. So what we know is that about 80 million people are affected by primary care health professional shortage areas, and almost 60 million are affected by dental health professional shortage areas. HRSA also says that if we were to fill all the voids, all the workforce needs in these so-called dental deserts, it would take over 10,000 practitioners to fill that void. But, you know, interestingly, overall access to dental care has increased significantly over the past 2 decades. So even though there may be some barriers because of cost and availability of providers, overall access is high, with almost 2/3 of Americans able to access care within the past year, ranging, and this was pre-COVID, ranging from 70% of American Indians and Alaska Natives to 63% of those who self-reported Hispanic ethnicity. But one of the significant barriers on workforce and in getting new graduates out to some of those rural areas is the cost of dental education. According to the American Dental Education Association, or ADEA, the average educational debt for dental students graduating last year was $292,000, up $5,000 from the previous year. And almost 4 out of every 10 graduates had debt in excess of $300,000. The American Dental Education Association estimates that this translates to about $700,000 in payback over a 25-year period. And because there are very few loan repayment or loan forgiveness options at the federal and state level, this indebtedness by new graduates often affects where they end up setting up practice or what practice model they go to. And it, of course, drastically affects access to care, again, for those that are in rural America and those the underserved and most vulnerable populations. But it's not that we're not having enough dentists. We really are, because what we've seen is over the past couple of decades, both with the number of new graduates from dental schools, plus me dentists pre-COVID again, foregoing or delaying their retirement, we've seen a 22% increase in the number of dentists in the United States. But it's really not quite that high, because if you compare that to the population growth and look at per capita increases, there's only about a 6% increase in dentists per 100,000 population. And again, because of that indebtedness and other factors, we know that many of these new dentists aren't going to rural America. You know, another change that we've seen in workforce, and Dr. Shah and I talked about expanded function dental assistants, and there are various alternative workforce models. We've seen an increase in independent and collaborative practice dental hygienists, public health hygienists, and of course, dental therapy. And this has really been a supply and demand issue. We've seen that because of access to care issues, there have been increased calls for these alternative models. So the dental therapy movement really began in New Zealand, some other countries, but it was brought from New Zealand to Alaska, to our Alaska Native tribes in Alaska back in 2000. And the way that works, for those unfamiliar, is that there is a hub clinic with a supervising dentist, and then these therapists who are trained, they have so many hours of didactic training and direct oversight clinical training, but they go out into these remote Alaska villages, mostly in villages that have sponsored their training. So they're from that area, and they provide the care under the indirect supervision of a dentist. In 2009, Minnesota became the first state to authorize dental therapy, and 12 to 13 states now have authorized some version of dental therapy. But I believe we only have dental therapists now in Washington and Oregon and in some of the tribes in Alaska and Minnesota. Another thing that is influencing the delivery of care, or if not now, in the very near future, will be the growth of the population of older Americans. In just the past 20 years, we've seen almost a 60% increase in the number of older adults 65 and older. And by 2030, the number of older adults will be more than double what it was in 2000. To put this in perspective, if all the US seniors over 65 held hands at the equator, they would circle the globe twice. To put it another way, if you looked at the current population of older adults, 54 million, that number would exceed the population of the 25 least populous states in the United States. What is driving this, of course, is the baby boomer generation living longer because of the marvels of science and health. And in fact, according to the Centers for Disease Control and Prevention, in 1950, the average life expectancy was just 68 years of age for both genders, with women living to 60 or 71 and men to 66. But by 2010, the life expectancy had risen a decade to 78 years for both genders, 81 for women, 76 for men. And at the same time, what we've seen is that the baby boomer generation, those that were born between 1946 and 1964, began retiring, reaching that senior citizen age in 2011, and this will continue until 2029. And in fact, by 2035, this is an interesting fact, it is projected that the percentage of adults aged 65 and older in the US population will eclipse the percentage of children and adolescents 18 years and younger for the first time in the US history. And as a result, we as oral health professionals, and in a much larger sense, healthcare in general, will have to be able to adapt and better treat the older Americans. One of the things we know with the older Americans is that with older age comes more chronic conditions. And with those chronic conditions come with them increased healthcare costs. So this graph shows that the annual cost per person increases by the number of chronic health conditions. So as you can see, if you look at this, an older American with 5 chronic conditions, which really is not that unrealistic or uncommon, averages more than $12,000 per year. And this has to be taken into consideration as we think about how to deliver affordable dental care to older Americans in the future. So let me shift gears and talk about this Surgeon General's report on oral health, the second ever, as I mentioned. And this is a picture of our Surgeon General, Vice Admiral Jerome Adams. And in 2018, not even a year into his term as Surgeon General, Vice Admiral Adams provided a charge to a team of federal public health professionals, including myself, to steer this report. And this charge, which is written here, provides an overview of the report. And that link down at the bottom, it's a YouTube link. You can also Google it. You can listen to Dr. Adams speak about oral health and this second ever report. For those that don't know, Admiral Adams, his background is as an anesthesiologist. And his passion for oral health really stems from his days as an anesthesiologist in Indiana, overseeing or helping assist with complex rehabilitation cases for dental problems in an operating room setting for both children and adults. This second ever report will consist of 6 different sections. Here are these different sections, but there's some topics such as community water fluoridation, oral health disparities and inequities, oral health literacy, and COVID-19 that will be interwoven in these different sections. And this report is currently still being developed, and we hope to have it published in the near future. So next, I'd like to discuss one of the other Surgeon General's priorities, and that is emerging public health threats. This was a priority of our current Surgeon General long before COVID-19. So there are several things I'd like to talk about. The measles outbreak of 2019, HPV-attributed oropharyngeal cancers, influenza, and of course, COVID-19. So in 2019, the US experienced the largest number of measles cases since 1992, with over 1,200 people affected in 31 states. The greatest cluster, about 73% of them, were in New York State. But what this outbreak really reminded us of is even though there is a vaccination available, we can't let our guard down and hope that these vaccinations alone will solve this. We have to continue as healthcare professionals to educate our patients and promote vaccinations. If I were with you in person, I'd ask you to raise your hand if you thought cervical cancer was the top HPV attributed cancer. Most of you would raise your hand, unless I'm speaking to oral health professionals, because we all know that really the top HPV attributed or cancer is oropharyngeal cancer, and it eclipsed cervical cancer a few years back. As you can see here, and I've highlighted it, there are over 12,000 cases per year of oropharyngeal cancer related to HPV, with the majority of those happening in men. And again, I think as oral health professionals, because we know this fact and there's a direct link between HPV and oropharyngeal cancer, I think we have an opportunity here to educate our patients about the HPV vaccine and to encourage them to get it. And in the US at least, the HPV vaccine has been approved for use from ages 9 all the way up to 45. Next, I want to talk about influenza. And we know that COVID-19 has received all the attention, but it looks like, based on data, that the influenza season this year, it may be the second highest, or last year's second highest in the number of hospitalizations last year and this year, surpassed only by the flu season of 2 years ago. And this graph shows that. And again, as oral health professionals, I think now, if you're in the US especially, now's the time to be talking to your patients and encouraging all of them to get their annual influenza vaccination. And of course, with COVID, what we saw that happened was in early February, we had less than a dozen cases, and this was considered an epidemic on foreign soil. And now we know that over 200,000 Americans and 7 million have died, and 7 million have become infected. And I don't have the worldwide numbers at this point, but millions have been affected by this virus. In the US, on March 17th, dentistry became directly impacted by the virus. So in a briefing by the White House Coronavirus Task Force, the COVID-19 response coordinator, Dr. Deborah Birx, who is pictured here with our president and vice president, recommended that hospitals and dentists cancel all elective surgeries over the next 2 weeks in order to free up hospital beds and space. This was followed by several other recommendations over the next week or two, including by the U.S. Surgeon General, by the Department of Health and Human Services, by the Centers for Disease Control and Prevention, by the Centers for Medicare and Medicaid Services, and others. And then most of our practices, as a result of that, shut down routine care. And we'll talk more about that in a minute. One thing we need to realize is dentistry really has been at the forefront of infection control implementation, beginning with our implementation of CDC guidelines back in the 1990s following the HIV/AIDS epidemic. With this pandemic, the Centers for Disease Control and Prevention Division of Oral Health established guidance for dental settings as they considered how to provide oral health services. These recommendations included things on minimizing aerosol generating procedures, adopting more rigid respiratory infection control methods, and screening patients for COVID-19 symptoms. We also saw that the Occupational Safety and Health Administration, or OSHA, which is responsible for worker safety, established guidance, and all of the state and territorial dental boards also established guidance and regulations for dental practices to comply with during the pandemic. And if you want to read more about the CDC recommendations, which were most recently updated in late August, you can click on that link at the top of this slide. And I'm going to show the next few slides are courtesy of the ADA's, American Dental Association's Health Policy Institute. But I want to show this one first. And what we know is that about 80% of dental practices did shut down and follow those either state mandates or CDC recommendations to only provide emergency services. And we know that hospitals in the US and around the world became inundated with COVID-19 cases. And it's really important to note that dental practices that stayed open and provided emergency care provided or played a very valuable role in doing so. In the US, at least, about 70%, according to the Agency for Healthcare Research and Quality, about 70% of those that go to hospitals to seek pain relief or care for dental conditions, about 70% are either uninsured or on Medicaid. And so by dental practices staying open, many dental practices were able to handle some of these dental cases since they couldn't go to the hospitals for routine or emergency dental care. So that's an important point to make. And as I mentioned, these are slides from the ADA's Health Policy Institute. This graph here shows the status of dental practice, and they track it. They did a national poll of practices in the US. And so if you look at this, the red indicates clinics that were completely closed and not even seeing emergency patients. The orange were those that were closed for routine care but providing emergency care. And the green, the yellow are those that were providing routine care, but they were at a lower patient volume than they were pre-COVID. And then the green are those that were providing routine care at the same level, same volume, at or above where they were pre-COVID. And what you can see is starting in March, the vast majority of practices were either shut down or providing emergency care. And by September, 99% of dental practices were open, and only 1/10 of dental practices were either closed or mostly just providing emergency care. So dental practices have rebounded pretty nicely since most of them start reopening in mid-May. So as we look at total patient volume, again, if we look at this graph, again, tracing it from April, in this case, all the way to September, what we see is an increasing number of practices seeing patient volumes at or above 50% of their pre-COVID level, which is indicated by the two shades of green on these bars. This means that from a public health standpoint, that many more high risk or vulnerable people are actually getting seen now in dental practices. And the final slide I want to show from the ADA's Health Policy Institute is one that where they measured consumer confidence in dentistry. And I'm not sure if other countries have done this, but in the US, this was a national poll. And what it showed was that 3 out of every 4 people either had been to the dentist, since most of the practices had reopened in mid-May, or were, quote, ready to go. There were an additional 7% who said they would be willing to go back to the dentist if they had some assurance of the safety of doing that by national or local medical or government authorities. These are the so-called assurance seekers. And there were only 14% of those that were polled who said they would not be comfortable going back to the dental office until there was a vaccine available. And I'll just briefly mention, since we're talking about COVID, one of the things that I was able to do, thanks to many, many different people. As the Chief Dental Officer of the Public Health Service, I saw the pandemic as an opportunity to perhaps break down some of the silos, communication silos that we see at the federal, state, and in organized dentistry levels. So, we often talk about the silos of care between oral health and overall health, but we also have many silos within dentistry and within the profession itself. And so in early March, I started this group called the COVID-19 Public-Private Partner Dental Coordination Group. And this group consists of representatives from 10 federal agencies, representatives from our state dental directors, from the state dental boards, and over 25 different dental and public health organizations. And what we did was we had a few in-person, or not in-person, few phone meetings and a lot of subsequent email contact. And we shared our messaging with one another and coordinated some of our responses on different things related to COVID-19. And maybe this will transition to a broader non-COVID group. And I think there's some value in that, because if we in oral health really want to work in one unified voice and break down these silos, that's kind of the first step, is to communicate with one another. So I've mentioned oral health and emerging public health threats. Let's talk about the Surgeon General's priority of opioids and addiction. So as the nation grappled, or has grappled, with the ongoing opioid epidemic, Admiral Adams has emphasized that the way we view this problem really needs to change. And he specifically said that the way we as a society view and address opioid use disorder must change. Individual lives and the health of the nation depend on it. Here's some facts, though. First, 1 in 7 people is expected to develop a substance use disorder during their lifetime. And in 2017, 21 million Americans, more than all of those who had all cancers combined, suffered from substance use disorder. But only 1 in 5 actually were able to receive treatment. The Surgeon General elevated this issue in 2018 with what's called a spotlight called Facing Addiction in America. And to find out more about this priority, you can go to that link at the bottom of the page. The Office of the Surgeon General also has developed a lot of educational materials that you can share. You can go to surgeongeneral.gov, or that page I just showed you, and print these out and share them with community leaders, policymakers, and of course your own patients. One other thing the Surgeon General did was he issued an advisory, which is like a high-level warning on naloxone or Narcan in reversing the effects of opioid overdose. In his advisory, he emphasized the importance of having this available for patients taking high doses of prescribed opioids, those illicitly using opioids, healthcare providers, including oral health providers, family and friends of those with a history of opioid use disorder, and community members, first responders and otherwise, who may come in contact with people at risk for opioid overdose. And he emphasized that everyone should become trained in the use of naloxone as well. When we talk about opioids, it's important to understand there have been really three phases, three separate waves of this epidemic. So first, beginning in 1999, which is the purple line on this graph, we started to see a rise in prescription opioid overdose deaths, and that kind of leveled off starting in 2017. Second, beginning around 2010, we saw a surge in heroin overdose deaths, as indicated by the orange line here, but that too kind of leveled off starting in 2017. And then finally, what we saw was beginning around 2013, we saw a sudden and pretty dramatic increase in overdose deaths attributed to synthetic opioids like fentanyl. However, there is some good news. If you look at the overdose deaths in 2018, we saw the first decline in opioid overdose deaths, showing that perhaps our renewed attention on this problem has been paying off. So next, I want to talk about the Surgeon General's priority on tobacco. And it's important to note that the first Surgeon General's report, and there have been over 62, I believe, reports. The first Surgeon General's report was in 1964, and it was written, it was the groundbreaking report on smoking and health. And of the 62 Surgeon General reports, over half of them have been tobacco related. And here's some of those different reports over the past 56 years, beginning with that first Surgeon General's report in 1964, commissioned by Surgeon General Luther Terry, and culminating earlier this year with the first report on smoking cessation in 30 years. And in between, there were numerous tobacco reports, including reports on women and smoking, e-cigarette use among youth and young adults, which I'll talk more about in a minute, exposure to secondhand smoke, and more. This report this year on smoking cessation, which came out back in the early part of the year, had as its major message that quitting smoking is beneficial at any age. And this report is available at their website that is listed there. And just as a reminder, we as oral health professionals still have a role in smoking and tobacco cessation, and e-cigarettes as well, and I'll talk more about that. And it's important to know that using tobacco use still accounts for more deaths each year than accidents, alcohol, HIV, suicide, homicide, and drugs all combined. The good news is we've seen tobacco use decreasing significantly. Since its heyday back in the 1950s and 60s, many factors have led to a steep decline in smoking, including increased cost of tobacco products, taxation, increased awareness of the dangers of tobacco, and stigmatization of those who use tobacco. However, and I told you I'd talk about this, e-cigarette use has increased. And in fact, in 2017, we saw, 2018, we saw the largest ever increase in the number of teens who used e-cigarettes or vaping, prompting the Surgeon General to issue an advisory on e-cigarettes in youth in December of 2018. So as this bar graph on the left here shows, nearly 4 out of every 10 12th graders reported vaping in 2018. But what's more surprising is that almost 2 out of every 10 8th graders reported vaping. In addition, what they're vaping makes a difference. While many older teens vape nicotine, e-cigarettes may serve as a gateway to adult tobacco use. A growing number of teens, as indicated on this graph, are reported to vape cannabis or cannabinoid products in their e-cigarettes. Early on, the argument was, well, use of e-cigarettes have no consequences, and it's safer than cigarettes. But what we saw last year was that one of the significant consequences did come to light. E-Valley, or e-cigarette or vaping product use associated lung injury, was the name given to lung injuries that were seen across the US as a result of additives used in e-cigarettes. Almost 3,000 people were hospitalized and 68 deaths were attributed to it. The mean age of those that were hospitalized was 24 years, with 15% of those being under 18 years of age. CDC, which did the data collection on this condition, no longer provides surveillance data, but this outbreak serves as a warning about the dangers of e-cigarettes. And as oral health professionals, it's important for us to think about our role in educating our patients, beginning with simply with our medical history. So many of our medical history forms still say, do you smoke or dip or chew tobacco? But we need to make sure we ask our patients, especially younger patients, if they vape or use e-cigarettes. And then if they do, to offer cessation counseling or refer them to someone that can. Another one of the Surgeon General's priorities that I'll briefly mention is something called community health and economic prosperity. The health of Americans, as we know, is not as good as as it could be, despite us spending over $10,000 per capita, the most in the world, on healthcare. Our poor health status creates costs and challenges for individuals, families, communities, and businesses. And it can be a drag on the economy as too many jobs are unfilled and productivity is adversely affected by poor health. So many of our poor health problems are rooted, really, according to HHS, in inadequate investments in prevention and unequal economic opportunities in our communities. So this community health and economic prosperity initiative uses a multi-pronged approach that focuses on engaging businesses to be community change makers and forces for health in their communities, implementing solutions to help improve and sustain the health of the communities, such as comprehensive smoke-free facilities and affordable housing, and strengthening communities to be places of opportunity for health and prosperity for all. The CHEP, or Community Health and Economic Prosperity Initiative, will result in the first ever Surgeon General's report on this subject, and that is under development as well, with the goal to improve health of Americans and help foster a sustainable and equitable prosperity for all. Our final priority that I'm going to talk about is health and national security. And what we know is that wellness is at the heart of the safety and security of our nation. Military performance is compromised if personnel are not healthy and physically fit. The Centers for Disease Control and Prevention note that obesity among active duty service members has risen 73% between 2011 and 2015, which reduces their readiness for deployment and increases their risk for injury. According to the Pentagon, more than 7 in 10 young people aged 17 to 24 would fail to qualify for military service due to obesity, educational deficits, behavioral health issues, or criminal histories. The Council for a Strong America noted in their October 2018 report that almost a third of those who sit down with a recruiter are immediately disqualified because of their weight. Our Surgeon General is committed to working with the defense and law enforcement sector to ensure that the readiness and resiliency of our military communities is improved. So I hope this presentation provides you with some insight, not just on oral health, but the priorities of the U.S. Surgeon General and how some of these issues affect or are related to oral health, and how these will be included in the second ever Surgeon General's report on oral health. So at this point, I'm going to stop sharing and I'll be glad to answer some questions.
Excellent. Thank you, Dr. Ricks. Wow, that was quite impressive. You covered a lot of things from vaccinations to COVID to baby boomer generation to high cost of dental for patients, high cost of dental education for doctors, substance abuse, obesity, and more. So just a few questions before we've taken a lot of your time already. What are your personal, having been in the dental space for quite some time, solution for actually caring for all of the baby boomer generation that's coming up and getting the workforce, the dental workforce ready for that? What suggestions do you have that we can contribute as clinicians?
Well, I mean, I think the first thing that we can do as clinicians is probably improve our knowledge, skills, and abilities to treat this population. Dentistry really sets itself apart from other professions in our zest for continuing dental education. And I think we need more education in treating the geriatric population. We need to learn new techniques and to get more comfortable in treating that age. So I think that's probably the first step. And then I think what we learned with young children, those under 5, especially in public health, is not only do you have to get comfortable with the population, you have to figure out where they're going, where they're being seen to reach them. So if we sit back and wait for people to come to us, the most vulnerable will not come to us. So, you know, I know, like, for example, in my career in the Indian Health Service, I would go to senior centers. They would meet and have a lunch every day. And I would do a denture check or do a quick screening on them. So, you know, I think we have to think about where older adults are being, are congregating and try to reach out to them and improve our continuing education to be able to comfortably treat them.
So community service is very important. I used to do what you're explaining as well in nursing homes. It establishes you in your community as a leader that cares about the geriatric patients in the community. So it's highly recommended that we do those things, such as denture repairs and checks, and just oral checks bedside in different settings for the elderly. High costs of dental. Doc, you were in Mississippi. In your days, there weren't that many corporations. It was a very intimate patient-doctor relationship between a patient and a doctor. Access of care wasn't as big of an issue as it is in some areas now. What do you think about the correlation of these high costs for dental students that you were presenting, 290,000 plus on average, encroaching up on $300,000? That's not small chunk. That's a lot of money. So these guys come out with all of this debt, and now their options are limited to either start their own practice, join a corporation, are going to public service, which I'm fond of option A and C. What is your take? What would you do if you came under these circumstances out of school? Would you actually bite the bullet and work hard and set up your own practice after a year or two? Would you join the corporations, or would you go into public service? You've done multiple of those things already, but what sequence, what would you recommend? This is a big topic in dentistry. You know, these kids, our colleagues, next generation colleagues coming out with this massive mountain of debt. But it's not the same thing as working in the public sector with not having the burden of finances versus the whole corporate setting. What is your recommendation to our younger colleagues?
Well, first of all, I cannot even fathom graduating from dental school and owing really $700,000, because over 25 years, $700,000. You know, all of us that bought a practice, we understand, or have bought homes, we understand the burden of debt. But as a brand new dental graduate, having that burden, I cannot even imagine the stress. And I say this from personal experience. My daughter just graduated from dental school this past year. But, you know, one of the things, if Dr. Shah and other dentists that are seasoned, if we go back to when we first got out of dental school, do you remember how much you didn't know? And you know, we all thought we knew everything. We thought our speed was up there, and then, you know, it really isn't. So my first and most important advice is to get a mentor. It is learn from seasoned dentists. And whether that means you join a group practice and with older dentists, whether you join corporate dentistry with seasoned dentists, or whether you know, do a partnership, I encourage you to do, or go into public health, do so with a seasoned dentist, because you'll learn so much in your first, especially in your first few years out of dental school. So that's regardless of whether you have an inkling for private practice or public health. The most important thing, I think, is get a seasoned dentist, and don't forget your continuing education, because it is a lifelong process. And so I think that would, I can't tell you whether you should, you know, go straight into public health or private practice or a dental support organization. They all have merits, but the seasoned mentor is probably my top advice.
I did something similar. Pretty much great advice is by joining or associating with another colleague for some time before using that as a stepping stone for my own practice. And you don't have to take $500,000 in debt to set up a practice. You can do it for quite inexpensive if you understand the mechanics and you increase your business acumen to negotiate with these vendors and all that goes with that. But congratulations on your daughter. She has big shoes to fill. Yes, this is great advice for our colleagues. We very much look forward to the report coming out, Doctor. I know you are also giving another presentation at the upcoming Global Summit. Do you know what the estimated date is for this report to be published so it's available to everyone?
Not yet. It is, so we have over 300 writers and reviewers for the report. And the first report back in 2000 actually took about 4 years to produce. So I do know that the team is working very hard, and we hope to have it in the near future, but there is a pretty robust clearance process through the federal government after the report is finalized. So I can't give you a prediction. I can just say it'll be in the near future.
Wonderful. And vaccinations, what is your take on that? Will you be vaccinating right away? Some of our colleagues are going to do it right away. Some waiting for more data. what's your take on that, especially on COVID right now?
I'm going to follow the CDC recommendations. Once the FDA, and I suppose you're talking about coronavirus, right?
Yes, I mean, there's a lot of talk about that going on right now.
I will say on the influenza, I encourage everyone to make sure they get their influenza vaccination. You can go ahead now. I usually personally wait until about mid-October to get mine, but I encourage that. As far as coronavirus, if the CDC recommends it, when the CDC recommends the vaccination, I'm going to get it. So,
excellent. I agree with you. That's what we should do, so we don't get sick and we don't make other people sick. Very good. Yes, you covered it all, Doc. Just some major topics of discussion have been addressed. We thank you very much for your time, and I look forward to the next time you will present and bring us up to speed on the insight of things that are going on within the government and their take of what the experts are saying. And thank you so much for joining us this morning. We appreciate your time.
Thank you, Dr. Shah, and thank all of you. I mean, all of us are in this together, and I appreciate all the work every one of you does every day to improve the world health.
Yes, that's our duty in the profession, and we have to step up to the plate now ever than before. And by the way, you're right, the offices are recovering. I'm very busy. As you see, I am in my scrubs today on a Saturday, because after this, in about 2 hours, we actually have a full load of patients on a Saturday, and it's been like this very much so in the last couple of weeks that we had to open up additional days and start caring for these patients. The three out of 4 that you mentioned that are comparable and going back to the dentist now. So yes, let's see if we can, the cavities are busy, so we're gonna get busy again. Thank you so much for coming on, Dr. Ricks, and have a wonderful day.
You too. Thank you. Bye-bye.
Take care.